You know, the human heart is an absolute marvel. It beats something like 100,000 times a day, all run by this incredibly precise electrical system. But what happens when that perfect timing just stops?
Well, when those electrical signals go haywire, the heart's chambers don't pump anymore. They just kind of quiver. Blood stops moving, the brain is suddenly starved of oxygen, and a terrifying clock starts ticking. It's a full-blown crisis, and it demands immediate, decisive action.
And this is what that chaos actually looks like on a monitor. That's not a heartbeat. It's an electrical storm raging inside someone's chest. The medical term for this is a cardiac arrhythmia, and it's a dangerous malfunction that can spiral into a full-on cardiac arrest in minutes. Now, a crisis like this rarely happens out of the blue. It's often caused by ischemia, basically a lack of oxygen getting to the heart muscle itself. And this analogy of a rubber band, it's the perfect way to describe the feeling of angina or chest pain. It's the heart literally crying out for help, warning us that its muscle cells are getting stressed out and electrically unstable. So when first responders are faced with this electrical storm, they don't just guess. They kick off this rapid, systematic process to decode the chaos and figure out exactly where the system failed. Before they even think about grabbing a defibrillator or drugs, the very first step is always the ABCDs. And this isn't just a random checklist. There's a life or death logic to it. Airway and breathing have to come first, because without oxygen, nothing else matters, right? Then comes circulation, making sure blood is still moving. This whole approach stabilizes the patient and buys everyone precious time to figure out the real problem. To fix what's broken, you first have to know what good looks like. And this, right here, is what we're aiming for. This is a normal sinus rhythm. Just look at how regular it is, those crisp, predictable peaks and waves. Each one of those is a perfectly coordinated contraction. This is our baseline. Now look at the contrast. This is an idioventricular rhythm. It means the heart's primary natural pacemakers have totally failed and let's call it a backup system in the lower chambers has taken over. But it's a slow, weak beat, and you can see that in these wide, really strange-looking waves. This rhythm is a huge red flag for profound heart failure, and it's just not sustainable for life. So here's the bottom line. We're dealing with an arrhythmia. It's a really broad term for basically any rhythm that isn't that nice, healthy beat we just saw. And the beauty of the ECG is that it gives every single arrhythmia a unique signature, which tells the clinicians exactly what they're up against. One of the most common points of failure is something called the atrioventricular node, or the AV node. I love this analogy. Think of it like a gatekeeper for the electrical signals trying to get from the top chambers of the heart to the bottom ones. When that gatekeeper starts malfunctioning and blocking signals, you get what's called a heart block, and that can slow the heart rate down to dangerous levels. Okay, so with the diagnosis in hand, the focus shifts immediately to intervention. It becomes a race against time, and the treatment path gets decided by one single critical question. Is the heart beating too fast, or is it beating too slow? The entire emergency algorithm splits right here. On one hand, you have tachycardia, a heart rate over 150, where the chambers are beating so fast they don't even have time to fill up with blood. On the other hand, you have bradycardia, where the heart is beating so slow it can't get enough blood around the body. Both are incredibly dangerous. All right, so for a patient whose heart is racing so fast that they're becoming unstable, we're talking plummeting blood pressure, confusion, the first line of defense isn't a drug. It's electricity. It's called synchronized cardioversion, and it delivers a controlled shock at a very precise moment. The goal is to jolt all the heart cells at once, silence the chaos, and hope that the heart's natural pacemaker can take back control. It's literally a hard reset for the heart. Now for the exact opposite problem, a dangerously slow heart that's causing symptoms. The first move is with a drug. The go-to first-line medication is atropine. What it does is block the vagus nerve, which acts like a brake on the heart. So atropine effectively tells the heart, hey, take your foot off the brake and speed up. And these protocols are precise for a very good reason. The initial dose is 1 milligram, given through an IV. Now, you might think a smaller dose would be safer, but it can actually, paradoxically, make the heart rate slow down even more. It's a perfect example of how in emergency medicine, the dose really does make the poison, or in this case, the cure. But what happens if atropine isn't enough? What if the heart just refuses to speed up? Well, that's when you go mechanical. Transcutaneous pacing uses big pads on the chest to send small, regular electrical jolts directly to the heart, forcing it to contract at a safe rate. It's basically an external pacemaker,
a bridge to keep the patient alive until a more permanent fix is possible.
So atropine is just one of the tools in the emergency drug cabinet. There's a whole array of medications ready to go, and each one has a super specific job, whether it's fixing the heart's electrical problem or its plumbing problem. Let's look at a few of the key players. You've got amiodarone. That's the heavy hitter, a powerful drug for the most life-threatening rhythms. Then there's adenosine. This stuff is wild. For certain fast heart rates, it literally stops the heart for a few seconds. It's this dramatic pause that can let the normal rhythm take over again. And of course, there's nitroglycerin for chest pain, but it's a powerful drug that opens up blood vessels, so you have to watch the blood pressure because it can make it drop fast. And speaking of nitroglycerin, its use for chest pain follows this really easy-to-remember rule of 3. 1 tablet under the tongue. Then you wait 5 minutes. If there's still no relief, you call 911 immediately and take a second tablet. After 5 more minutes, you can take a third and final dose. If that doesn't fix the pain, it's a sign of a true cardiac emergency, and you need to get to a hospital.
A lot of times, a failing heart can't pump right, and that causes fluid to back up into the lungs. That's heart failure. To treat it, clinicians often use this Diuretic Duo. Furosemide is a really powerful water pill that gets fluid out fast, but it also gets rid of potassium, which is critical for heart rhythm. And that's exactly why it's often paired with spironolactone, which helps the body hold on to that essential potassium. It's a perfect balancing act. You know, from that first moment of collapse all the way to the final life-saving intervention, every single step is a link in what we call the chain of survival. And every single link is absolutely indispensable. So what are the big takeaways here? Well, first, assessment always comes first. That's your ABCDEs. The ECG, that's your roadmap. It guides every single decision. The choice between electricity or drugs, it all comes down to whether the patient is stable or unstable. And finally, just remember that we're often treating 2 separate problems at the same time. An electrical problem, the arrhythmia, and a plumbing problem, like the blocked arteries that probably caused it all in the first place.
We've seen some incredible science that can literally bring a heart back from the brink. But all of this reactive power, it kind of begs a much bigger question, doesn't it? How do we get better at preventing the heart from stopping in the first place? And that is a topic for another day. Thanks for joining us.